Good morning, everybody. Dr. Pradeep SRINIVASAN from Bangalore. Another teaching video from the Refer series under Medinet. Today we are going to see about anomalies of Ductus venosus and umbilical vein. Ductus venosus is a trumpet shaped vessel connecting the umbilical vein which enters the fetus from the placenta through the cord to the IVC. So the junction of umbilical vein and the inferior vena cava is a extra vessel called as the ductus venosus. It has got a special purpose and it is a fetal shunt. So it shunts about 25% of the oxygenated blood into the left atrium via the foramen ovale, thereby bypassing the right heart circulation and the lungs. So this it does because it has a muscular wall and it is at an angle as shown here. So here you can see this is the umbilical vein. It enters the liver and it reaches the portal sinus. That's the right portal vein. This is the inferior vena cava. These are the hepatic veins. That's the right atrium. Here we have the foramen ovale. Now this structure between the umbilical vein and the IVC here is the ductus venosus. So this is at a particular caudocranial direction and posterior anterior direction, and it has a muscular wall and it squeezes the oxygenated blood from the umbilical vein in a faster velocity and in a particular anterior and leftward angle. So the blood from the ductus venosus mixes with the deoxygenated blood in the IVC. The blood in the IVC passively flows into RA and RV, whereas the blood in the ductus venosus actively with a large velocity enters the RA. Instead of going into RV, it shunts across the foramen ovale into LA. So the oxygenated blood is bypassing the right heart and entering into the left heart directly, so that the highly oxygenated umbilical vein blood from the mother goes to the left atrium, left ventricle, and then into aorta to the brain, body and myocardium. Also you can see that the high maternal pressure in the umbilical vein is dampened by the ductus venosus, and this pressure is obliterated and the right heart is saved from the high maternal umbilical vein pressure. So the ductus venosus also protects the heart by preventing the high maternal pressure falling on the heart. In fetal hypoxia, the ductus venosus dilates and allows more blood, oxygenated blood, to bypass right heart and go into the left heart of the fetus. Now this is a picture of the umbilical vein entering the fetal abdomen at the umbilicus. So the umbilical vein initially goes below the abdominal wall, immediately takes a 45-degree curve into the liver, goes close to the IVC, and before entering into IVC enters the ductus venosus. So you can see this is a passive umbilical vein flow velocity, and here you can see the aliasing or high ductus venosus velocity. This is the color Doppler in a mid-sagittal plane of a 12-week fetus. This is an important picture to be documented in all 12-week fetuses, because this picture shows the cord with the umbilical vein, umbilical arteries, the oxygenated blood going into the umbilical vein, taking a gradual angle into the liver, reaching the IVC region, and from there it shunts blood into, it reaches the portal sinus, then a part of the blood shunts into ductus venosus and the IVC, and it goes into the right atrium. This red structure is the descending aorta. This is the celiac axis, that's the IVC. Then the descending aorta empties into the umbilical arteries, which again goes into the umbilicus to reach the cord. This angle subtended by the umbilical arteries with the with the descending aorta is called as the K angle. That is the Cine loop showing the flow from the umbilical vein entering into the ductus venosus and then into the IVC and the complete circulation. This is a coronal view showing the ductus venosus. So that's the umbilical vein, this is the right portal vein, this is the hepatic vein, this is the IVC, and this structure is the ductus venosus. That's again a Cine loop of mid-sagittal plane. This is a 20-week fetus, and you can see this part is the ductus venosus. In 2D, you can see the ductus venosus here. So that is the IVC, this is the ductus venosus, and that's the portal sinus, that's the ductus venosus. In 30 weeks, this is the ductus venosus. That's the IVC, hepatic vein. Here we have the umbilical vein, and that's the ductus venosus. That's a Cine loop of the 30 week showing blood from umbilical vein shunting into the IVC across the ductus venosus. So this is how we document the presence of ductus venosus at 13 weeks, 20 weeks, 30 weeks, etc., which can be done in a mid-sagittal plane or in an oblique coronal plane. The Doppler also has to be done, and the ductus venosus will usually have flow only above the baseline. It has an S, D and A wave, and the A wave will not show reversal in the ductus venosus. Now we will come to agenesis of ductus venosus. When we are not able to show this anatomy, we are not able to show the Doppler of the ductus venosus, we should suspect agenesis of ductus venosus. Now, points to be remembered are This agenesis of ductus venosus can be associated with persistent right umbilical vein. So normally the umbilical vein which we see goes leftward, and it is between the stomach on the left side and gallbladder on the right side. It goes to the liver and takes a rightward turn into portal sinus and right portal vein. So this is the normal left umbilical vein. When this is not there, and when the umbilical vein goes to the right side and the anatomy is different, then we will suspect persistent right umbilical vein. So whenever we have persistent right umbilical vein, we have to look for immediately agenesis of ductus venosus. Also, once the ductus venosus is absent, obviously the umbilical vein drainage will be different. So we have to look for anomalous umbilical vein drainage. The portal venous anatomy development depends on the umbilical vein flow into the portal sinus. So if the umbilical vein does not flow into portal sinus, then we will have portal vein agenesis, which can be complete or partial. So the moment agenesis of ductus venosus is suspected, look for persistent right umbilical vein, abnormal umbilical vein drainage patterns, and for portal vein agenesis. Also, ASD, VSD, DORV can be associated with agenesis of ductus venosus, and trisomy 21, 18 and Turner's can be associated with agenesis of ductus venosus. Once there is a anomalous umbilical vein drainage, we have to see whether it is intrahepatic or extrahepatic. When it is intrahepatic, the umbilical vein may normally go to portal sinus, but there may be an extra vein which drains into right atrium. Or the umbilical vein may go into portal sinus, ductus venosus won't be there, and the drainage will be through hepatic veins into IVC. So the two types of intrahepatic shunts or patterns in absent ductus venosus are: one is umbilical vein going to portal sinus and another extra vein draining into right atrium. Second is umbilical vein going into portal sinus and via hepatic veins blood going into IVC and right atrium. Now we will look at extrahepatic umbilical vein drainage. Here the umbilical vein bypasses the liver and it can drain into iliac veins, mid IVC, renal veins, upper IVC, or into directly right atrium. So whenever this happens, there is risk of high pressure falling on the right atrium with cardiac failure and high drops. And whenever the umbilical vein bypasses the liver, the portal veins don't get their stimulus and there can be portal venous agenesis. So remember, anomalous umbilical vein can be intrahepatic or extrahepatic, and look for the type. So here we have 6 pictures. Picture 1 shows the umbilical vein draining into the portal sinus and into IVC through the ductus venosus. Here we have the umbilical vein bypassing the liver and draining into upper IVC. Here we have umbilical vein bypassing the liver and draining into lower IVC. Here we have umbilical vein going into portal sinus and through hepatic veins into IVC. Here we have umbilical vein draining into iliac veins, and here we have umbilical vein draining directly into right atrium. So these are the normal and 5 anomalous umbilical vein drainages which one can pick up in fetal life. Now we will see a case of umbilical vein draining directly into right atrium. So here you can see that this is the IVC, that's the umbilical vein, that's the right atrium, and it enters directly into the right atrium. So you can see that it is first of all tortuous. Secondly, from the lower abdominal wall as it enters, it does not take this smooth 45-degree curve towards the heart. It goes a little more higher up, then becomes very tortuous, enters the liver, and then shunts into the right atrium. So as I said, we have to look for portal venous anatomy. So here we have the umbilical vein coming towards the portal sinus. I am not sure whether it shunts into portal sinus because it takes a U-turn here, but however the right portal vein is patent. So most probably it is shunting there, but however there is no portal vein agenesis, and you can see it draining into the IVC. Now this is a picture showing the right atrium and IVC, which appears normal, and what was very surprising was at the junction of the umbilical vein with the right atrium, the Doppler showed flows resembling ductus venosus. So that was not explained. But the IVC waveforms you can see are normal with a normal A wave reversal. So that's the umbilical vein directly draining into right atrium. And you can see the cine now, tortuous umbilical vein and direct entry into the right atrium as shown in this cine. That's an axial view. You can see the umbilical vein. We are coming from above below now. That's the right atrium. That's the hepatic veins. IVC, umbilical vein, tortuous umbilical vein going into the cord outside. Now coming back, the two umbilical arteries and the umbilical vein coming into the liver, becoming prominent, ectatic, going into portal sinus, but having an abnormal vessel shunting from portal sinus directly into right atrium. There, that's the umbilical vein going out, becoming tortuous. That's the portal sinus. That's the tortuous umbilical vein. That's the exit. So picture without color showing the umbilical vein. This is a prone view. You can see the umbilical vein entering directly into the IVC. So that's the IVC and RA, and you can see that the umbilical vein enters directly into RA. So see the angle of the umbilical vein. Normal umbilical vein is smooth at 45 degrees. This is curved with convexity superiorly with an increased angle with the IVC. Now this is another case where the umbilical vein drained into the IVC. So here you can see that umbilical vein draining into IVC. So that's the umbilical vein, that's the IVC, and that's the light draining into the IVC. So today we saw a case of umbilical vein entering the liver, going towards portal sinus and becoming tortuous and having a large ectatic continuation of vein or an extra vein shunting into the right atrium. Unexplained part was there was ductus type of flows, ductus venosus type of flows at the level of the entry into the RA. Remember, whenever you see persistent right umbilical vein in the lower abdomen views, then immediately document that and look for ductus venosus anomalies. When you don't find the ductus venosus anomaly, then document the type of anatomy which the umbilical vein takes. See whether it's intrahepatic or extrahepatic. If it is intrahepatic, see whether it is hitting the portal sinus or hitting the portal sinus and showing an extra vessel like today's case shunting into the RA. If it is bypassing the liver, see whether it goes directly into RA or into IVC or into any other iliac vein. When we have a case like this, document the portal venous flows, because an isolated umbilical an isolated ductus venosus agenesis with the intrahepatic shunt of the umbilical vein has good prognosis, whereas a ductus venosus agenesis with an extrahepatic shunt can overload the heart and cause cardiac failure. But if that does not happen, then portal venous agenesis will cause severe morbidity in the children after birth, because there will be fibrosis and cirrhosis. Agenesis of ductus venosus needs amniocentesis and FISH for 1821 and karyotyping. Thank you very much for a patient hearing. Those interested in learning more and those interested in pursuing online certificate courses in fetal echocardiography or in fetal aneuploidy can WhatsApp me on the above number. These are designed certificate courses with embryology, anatomy, protocols, advanced biometry, and discussion of a large number of cardiac anomalies with an exam at the end. Those who pass will get a certificate of online fellowship in fetal echocardiography or in fetal aneuploidy. This is under the REFER series. REFER stands for Radiology Education for Enhancement of Radiologists. Thank you very much. Happy learning. Jai Hind. Dr. Pradeep Srinivasan from Bangalore under the REFER series.